First of all, I want to welcome you here again this morning. And before I launch myself into my talk, I want to remind you about what yesterday was about and how my talk and the other talks this morning fit in. Yesterday, we had splendid presentations and discussions from basic scientists who have been involved in the study of memory, the study of the brain in relationship to memory, and in the study of the psychological matters that relate to our subject, particularly issues of the interpretation of diagnoses, the understanding of issues that relate to repression, and alternative explanations that to the ones of sex abuse that have been offered presently. I found it an extraordinarily interesting set of presentations. I hope you all enjoyed them. My purpose today in reminding us about that is that my talk is entitled "The Do's and Don'ts for the Clinician Managing Patients." And to speak to people about the practice of psychiatry, in particular in relationship to this subject, is an awkward business, as we've all discovered. We've discovered that we're challenged by questions about the science behind our work, about our own personal experience, and ultimately about our standing to be able to make a point and to direct others in their practice. And so long before I come to tell you the kinds of do's and don'ts of this area, I believe that it's very important that we establish where we find our standing, or where I find my standing to tell anybody what to do. And that point leads me anyway, to make an important point about psychiatry that I made yesterday and I want to repeat today. And that is that psychiatry is not a science. Psychology is a science, chemistry is a science, psychiatry is a practice that employs science to help it in its practice, but is not a science itself. Psychiatry, like any aspect of medicine, surgery and the like, is like other human practices. What are human practices? Well, farming is a human practice. Architecture is a human practice. Painting is a human practice. Again, all of them use science, but not only science, to direct its practice. It uses other things as well. It uses, for example, the standards and traditions by which a practice has evolved. That's the way a practice learns from its mistakes. I'm going to talk a little bit about that. It also advances a practice on the basis of an organized personal experience. And that gives people standing to speak about a practice. And I'm going to talk to you about that. And finally, a practice is organized around outcomes, effects of particular practices. And I'm going to talk to you about that as well. And from all of those things, I'm going to derive a set of relatively simple aspects of do's and don'ts. But I believe that we have to put these things out, the logics, the backgrounds, the traditions, and the like, in order to be able to say anything that is, well, worth listening to, okay? And I hope you'll find that what I'll say eventually is worth listening to on the basis of what I give you as background. Now, to begin, let me see, I need my glasses to read this. Whoa, that's it. I'll go back now. One of the things is you got to learn the practice of pressing these odd instruments. Right. I want to remind you of the ultimate logic that rests behind all of these issues, because if you don't understand this and make this an aspect of the practice on which you work, then all the rest of the arguments will not be coherent. And that is this fourfold table here. Again, I went over it yesterday, but for anyone who wasn't there, and also always, I like to repeat this because it's the foundation on which I base my experience. Oh, by the way, before I go on to talk about what I say is my experience has been generated in a company of people at Hopkins. And that company has been tremendously important to me. The discourse and language, the discourse and interactions we've had have been very important. For example, this fourfold table really emerged out of a conversation that I had with one of our distinguished psychologists, David Edwin. And without his interaction with me, I wouldn't have seen this as clearly. Likewise, some of the experiences with patients I've shared with Mark Fishman and Pat Santora. Finally, many aspects of the legal side of this, Dr. Jeff Janofsky has helped me tremendously on. None of this, then, they're responsible for. None of these opinions they're responsible for. But without them, I would not be able to be as clear and coherent as I think, at least to myself, I am. Anyway, this is the fourfold table that David and I saw. Well, as you know, in a place like Hopkins, it's this give and take that makes such a tremendous difference. And David and I hit upon this together one day. That is that the historical abuse, that is, if people divide themselves up into those people who have been abused and those people who haven't been abused, obviously. So we have the column yes for those individuals abused and those who have not been abused. At the same time, we know some people have memories and some people don't have memories of being abused. Hence, the rows, the yes row and the no row for the memories, make a fourfold table with 4 cells in it. That is, people who were abused and remember it, we're going to call a hit. Those who were not abused and have no memory of it, we call the unaffected. Those who had an abuse and don't remember it, we call the forgotten. And those who were not abused but have a memory of it, we call the false alarms. And as I said, there are people in every one of these cells. And I'd like to remind you that nothing that's happening at the False Memory Syndrome Foundation or any of the things that we're saying today deny the fact that there are both people who remember and have been sexually abused, and they number large, and we know that there are people who have been abused and have forgotten it. We heard that from yesterday from Linda Meyer Williams, and we know that many of the forgotten come from the early childhood amnesia phase of life, but there are other people who forget this for other reasons that we don't yet know about. So we know that there are people in the forgotten column, forgotten cell. The problem is that when someone changes from saying that they have no memory to having a yes memory, that fact does not determine which column they go up. And it is the responsibility, in logic now, of a psychiatrist or a psychotherapist to show a good faith effort in practice to make this decision. Did the patient go up this column, or did the patient go up this column, becoming a hit or becoming a false alarm? And the problem, right from the beginning, has been that a good faith effort is not made in deciding this matter. And on that, we begin our consideration. In fact, as I'll tell you in a little while, the very fact that someone changes his memory or her memory from a no to a yes puts the family in the most awkward position in relationship to everybody around them. If an open and thoughtful consideration isn't made to make this decision. In fact, in the media and the law enforcement and everywhere, it is assumed that it's always this column that people ascend. And part of our issue in relationship to practice is to develop with individuals a sense of how they might look at which column is being ascended and making that a standard part of practice. Okay, I'm going to come back to this table later, but now I want to talk about my experience. My experience, after all, is It's not a universal experience. Everybody's experience is limited. But I have had now a very growing experience over caring for these patients and these families. It began really in a small way in the early 90s, back 1990, 1991. So by the time I wrote the paper entitled Psychiatric Misadventures, I had only accumulated about 5 cases. But since then, the accumulation has gone extremely rapidly. I've seen with my group about 35 cases now, and this is essentially the organization of the first 15 cases. Now, it may well be that I have some bias of ascertainment. It may be that people come to see me because they wish to get the kind of open-minded consideration that I offer. I also tell them it's going to be a very arduous procedure in which to come to a conclusion. I do put them through the ringer, let me tell you, because the whole idea of being open means that you have to consider both sides, and it's quite arduous. However, in these 15 cases, and these are the first 15 cases that I've seen and been involved with, there were plenty of reasons for doubting that this family had abused its child. There were plenty of reasons, and those reasons were in all of these cases not given much credence. That was what was surprising to me. The problem, I'm sure, in part was in order to deal with the problem of the accusation, you have to prove a negative. You have to say that somebody is making a claim. You have to say, well, no, it didn't happen. Now again, in the logic of the situation, you can't prove that something didn't happen. Okay? Proving a negative, as anyone knows, is essentially impossible. It's certainly very difficult. But there are always, if you look at a situation closely, reasons for feeling confident or reasons for feeling doubtful. In all of my cases, or at least 14 out of the 15 cases, I have had and developed very strong reasons for doubting the likelihood of the abuse. And I have those reasons from doubt laid out in these columns. For those of you in the back of the room, you probably can't see them, but from the strongest reasons for doubt to perhaps the weakest reasons for doubt, from left to right. In 40% of the cases, though, the strongest reasons for doubting that the abuse occurred were that the original accusers retracted completely their claim. In other words, they went from a no to a yes back to a no memory. And once again, I want to make the point that that doesn't completely prove that it didn't happen, because it could be that they got their memory and that was accurate, and now they've lost it and that was inaccurate. All I'm saying is a strong reason for, and that's the issue of proving the negative, you see. The reason for saying that this is powerful is that it's powerful as a reason for doubt. The patient originally claiming, 6 of the 15 claimants have retracted. In a quarter of the patients, the reasons I doubted the correctness of the abuse was that the patient got the idea during hypnosis. And we heard yesterday, very importantly, that hypnosis is not a way to find a fact, but rather to enhance a person's conviction of a fact. And hypnosis is being used again and again on patients in the midst of evaluations with the hope of finding an abuse. In another quarter of the patients, the claim was that they were involved in a satanic cult. And as I told you before, I don't believe that there are satanic cults out there. And so when somebody says that it happened in a satanic cult and my father and mother are running around in red robes in the middle of the night, I think something's up. And it's not with the parents. 50% of them had other improbable memories. Now, what do I mean by an improbable memory? I think, for example, I had a patient who made a claim that she remembered her father and uncle inspecting her lower parts when she was 10 months old. And she was not able to speak, but she was screaming out for her mother's help, she says, and she remembers. Now, look, I don't believe that. Okay? And I think that's a very improbable memory, and it makes me doubt. About 3/4 of them were given The Courage to Heal as an effort, the book as an effort, a suggestive book as an effort to develop their opinions. 2/3 of them were put into incest groups of people who were hits, who had really remembered, or people who were in the process of recovering, a so-called recovering a memory, and so they were put in an incest survivor group, and that's what encouraged them. And finally, 3 of the families, 3 of the accused passed a polygraph, and that they had not abused their child. Now, I put these out as reasons for doubt from the strongest to the weakest, but you see that in 14 out of the 15, I had strong reasons for doubting them. There was another intriguing piece of evidence that made you wonder about the whole body of cases, and that was who was accused in my 15. About 60% of them, the father was accused, and the father is usually the majority, but 10% somebody else was accused as well with the parent. But the interesting thing was that 30% of the mothers were accused of being the sexual offender. Now, we have studied pedophilic offenders at Hopkins and elsewhere, and to find a mother, or a female for that matter, interested in pedophilic sexual abuse is rare. Now, by rare, I mean it's about 5% of the population and maybe less. Those individuals, women who are involved in that, have serious mental illnesses. They are psychotic when they're involved in this. The erotic interest in the child is not a female problem. And finding that 30% of these people, of these accused, were mothers, should make you very suspicious of the truth of the accusation. By the way, one of the other things that you'll hear is that somehow or another the False Memory Syndrome Foundation, or the group of us who are interested in studying this, are not on women's side. As far as I know, all mothers are women, and they deserve, and you'll see another way in which mothers and spouses are at risk in this matter. But anyway, this was another reason for doubting. Finally, not as a reason for doubt, but for a reason of understanding the clinical situation, I want to show you that of the 15 patients, they all had some other psychiatric problem that was also going on. 7 of them had major depressive disorders. 6 of them had personality disorders of the cluster B variety. But almost all of them had some here and now adjustment disorder that they were working on. That's what brought them, it was these things that brought the patients into therapy to begin with. They didn't go into therapy saying, I'm abused, or I remember being abused. None of these patients did. All of them went into therapy because of the depression, the adjustment disorder, or some aspect of their personality disorder that had caused them difficulty. And it was within the treatments for these conditions that they found, therapists together found and recovered some memory. So these are psychiatric patients we're talking about, not people wandering around the streets who just suddenly got the idea, well, I've been abused, and go to see somebody. We see patients who have known they've been abused all their lives and come in to talk about that matter. This cohort of patients wasn't like that. They went in for something else. When all of this came up and I began to get this experience, it I had a second aspect of my experience that was extremely interesting and quite telling. After all, I've been taking care of patients and teaching how to take care of patients for over 25 years, and I sometimes agree and sometimes disagree with my colleagues over an evaluation or a formulation of a case. And I usually call them up and we chat back and forth friendly enough, and sometimes I persuade them, sometimes they persuade me, and we move on in the care of the patients. And in all of these cases, I would call somebody and say, gee, you know, I'm looking at the family and in a different way. What want to tell me some of your information because I might be missing something? But this is what I get back. And it's unique. This is new. I get this idea that as a therapist and not an investigator, it is not my responsibility to verify the accuracy of my clients' reports. This is, you know, I've never called up somebody, for example, who in the midst of a manic disorder believed that they that they were a millionaire and could throw their money away, and had a therapist say, well, I don't care whether he throws his money away or not, it's not my doing. They say, oh yeah, we better help him. And in this case, this statement can be parsed in ways that show its inadequacy. It says, as a therapist and not an investigator. That implies you do therapy before you do an evaluation. Okay? Evaluation first, therapy second is an ordinary rule of any doctor. Okay? And so saying it's not my responsibility to verify, well, it is your responsibility to somehow attempt to verify the accuracy of your client's reports, especially if you're a psychiatrist dealing with people with mental illness. I mean, it's mental illness that leads people to have abnormal reports, and we want to check it. Now, that doesn't mean you have to send a bevy of detectives out and try to find things and all that. It just means you have to make some kind of good faith effort to be in contact with sources that could explain or make you understand the patient's situation, or give you some alternative ways of approaching the patient and seeing them, particularly in some of the ways that were talked about yesterday by George Ganaway and the like. That there are other ways of thinking about it, and you don't want to be entrapped, like Donald Spence told us, in simply a narrative. In fact, what turns out when you talk to these therapists is that you find that they are making a very standard logical error. Not standard in medicine, but a standard in logic that we've known about since Aristotle's time. And that is, I don't want to remind you of your first course in Philosophy 1 or Logic 1, but it was back in there. It was the logical error called affirming the consequent. I'll explain it for you just to remind you. I know you all remember that, but it goes something like this, that if A, then B, but if B, not necessarily A, because C could produce B, D could produce B, E could produce B. Have you got it? You see? A can cause B, but something else can cause B. And that's what's happening. Many therapists know that trauma can cause mental disorders. We talked about them, all kinds of disorders, I suppose, but primarily a trauma can produce some kind of post-traumatic state. But mental disorders, simply finding a mental disorder, the list Dr. Lindsay gave us yesterday, does not say prove trauma, even though trauma might produce mental disorders, because contemporary stress, medications, genes, temperament, as well as trauma can produce mental disorders. And it is intended upon the therapist to evaluate the patient and find out whether contemporary stress, medications, genes, temperament, or any other thing could be provoking this mental disorder, rather than just assume that because mental disorders sometimes are caused by trauma, there must be a trauma there to begin with. And that's what the therapist is telling us when he or she says, it's not my responsibility to verify. What they're saying is not my responsibility even to work the patient up. And that's not right, okay? And this logic in itself shows you that. Then let's look at the characteristics of the pseudo memories that I saw amongst the patients, because it's becoming very standard now. Everybody is seeing the same thing about the patients, and my collection is just a small sample from amongst them. First of all, these pseudo memories occur in distressed people, that is, people who have mental disorders of some sort, who have many different diagnoses. If you examine the patients, you'll find many different conditions with them. The pseudo memories do not begin in full light. They begin as very vague and uncertain suspicions, sometimes produced in therapy, but sometimes, by the way, produced just by reading the magazines. Other sources of information. Say, well, I listened to the Geraldo program, and they were talking. I suspect maybe something might have happened. Maybe that could explain why I'm distressed. The suspicions, though, are very affect-laden. It's not just something, well, it might be interesting. It is, gee, I have this distressing feeling. And the initial memory is envisioned with great difficulty. The patient does not come popping out. It comes out of work with the patient and work of the patient, thinking about what these suspicions could mean. Once the first one has occurred, though, later memories then flood in, and over time they swell to astonishing tales of the most vile sort and the most amazing kinds of things that would require not only the physical abilities of great athletes, but the equipment of tech and techniques and that would be more expensive than buying a Nordic track. Let me tell you, to get some of the equipment that they speak about. The idea is these memories are very sensitive to suggestion. That is, they meet other people and hear about what they have thought, and then they begin. For example, out of Sybil, the idea in Sybil that the assaults occurred in the green room. Well, we hear a lot about green rooms now in people's memories. They're very contagious. They expand in a group setting. If you put these patients in with other patients who are working on the same thing, the ideas quickly and memories quickly expand, and certainly with hypnosis and guided imagery, they become astonishing. The post-traumatic stress responses, and I put that in quotes, but I want to make the point that by that I mean things like flashbacks and dreams. They don't come before the initial memory or the initial therapy, but follow after it. You have a person who's there with depression and anxiety. They don't have these dreams and memories. You begin in therapy, and then these flashbacks and things begin to appear. They appear, they're terrifying, they're very distressing, as you might imagine. Now, I always want to remind people that post-traumatic stress disorders can follow, if they follow the treatment, they may be being provoked by the treatment. That the treatment itself has become the stressor. It is a stressor because it's saying, imagine this with me. Try to imagine who could have maybe abused you, who could have caused you this suspicion. And then the worst fears of people begin to occur after the therapy starts, and then that's used to confirm that they must have had this happen. Okay? Now, by the way, flashbacks and dreams, I'm not sure I have to tell you this, but it really is important to remind you that certainly dreams are not evidence of reality. They do not tell you things that happen, but they do tell you things that you're afraid of, even things that are your worst fears. And in an audience like this, I always want to remind people that everybody has had that event themselves. Everybody. Anybody who has been to college and worked hard at college occasionally has the dream that they're going to take an exam and they didn't prepare. Okay? That's a post-traumatic stress of a mild sort. It's the sort of being it's a post-traumatic dream. But listen, you always prepared for those examinations, didn't you? Right, you did. But you're running through the yard or something. I got to get over to Memorial Hall, but God, I didn't study, or I didn't do it. I didn't check off when I was supposed to. That's what happens with these patients. They get told about this possibility, and then the dreams begin to follow. But the most important thing is that the memories tend to block therapy directed to the here and now, to the adjustment disorders. They block the therapy from going on and make the therapy interminable. Okay, now, what do I think that we're dealing with? What I think we're dealing with, amongst the false alarms anyway, is what I call a socially constructed artifact. We're losing it here. A socially constructed artifact. I used to use the word hysteria, but I've given that up because it doesn't explain, and it has all the problems that the word hysteria carries with it, all the extra baggage. But it's the term that, hysteria is a term that used to be used for this. But by an artifact, I mean that these are products of a psychological kind produced by the hands of somebody else, the culture, the therapist, the patient. And my nice homely example is, to make sure you understand the word, is that archaeologists look at the ground out in the Southwest, and they want to distinguish three cornered stones that they find there into two groups. One in that shape because of the action of rain or wind or glaciation, products of nature, from arrowheads, which are the products of human beings. An artisan has produced them, and they call them artifacts. And these false memories are likewise artifacts, in my opinion, built from the ingredients of some aspect of personality, some issue of mental distress, as we heard about yesterday, and the cultural idioms that permit that mental distress at the moment to make sense. And it's these things, particularly the idioms, sometimes transmitted by therapists, but also transmitted by the media, the print media as well as the television media, to make this kind of false memory to be created. The artisan is the culture, including the therapist. What's the purpose? The thing about artifacts are that they have purposes. The arrowheads have purposes. Cups have purposes. These are artifacts. This has purpose. And that's what Donald Spence and Ganaway and others were talking about yesterday. They are saying that these false memories fit into the life story of the person as a kind of explanation. The person is distressed for something else, and the false memory gives them an explanation that fits. And, by the way, a justification for being ill or disturbed. And it's that, these are the two features that an artifact has. Now, listen, I didn't make this up. Again, this is this issue of standing. Where do I have standing to make such claims besides my personal experience? Well, I got an awful lot of help from Sigmund Freud. We're cutting off his head. This is him about age 39, about the time of the writing of the Interpretation of Dreams. And he's got a bad press now because of Jeffrey Mason and Janet Malcolm. They're fighting it out. They deserve each other and all, but they're fighting it out. However, Freud was a very good doctor. Okay, he not only had an understanding of things, but he had an approach to patients that allowed him to both make a mistake and correct it. And what did he say about these things? He, as I say, he's got a bad press, and you really have to go back and just read his 4 reasons for doubting that most of the childhood seduction reports that he had originally made claims for didn't happen. And this is this, for example, you can find this in a number of places as well. Dr. Slavny talked about it briefly yesterday, but I'm choosing these 4 from his letter to Fleece that he wrote in September 21st in 1897. And look at these. This is a doctor's approach to an error. He first of all said, I doubt it because I fail to finish my therapeutic analyses successfully with this idea. The therapies are interminable. They go on, he said, forever. I don't get through anywhere. That's a good reason. We know the same today. The implausibility, he said, of many of the claims. That is, when he went to check or looked at things, it couldn't have happened. And, as well, and this is what people get after him for, the implications of a huge prevalence of pedophilia. I think, by the way, that there is more pedophilia than we might have discovered, but than we might have thought originally. But he and I say that we don't believe that this much is happening. Thirdly, and I think in relationship to the science we talked about yesterday, this is a very telling one, the recognition that in the unconscious there is no criterion of reality. I think if Freud were here today, he would say, with Dr. Schachter and with Dr. Larry, I'm losing my names up here today, Larry Squire, that the important thing to remember in consciousness, not just in consciousness, in the brain itself, the same brain processes that are engaged in fantasy are engaged in reality thoughts. They aren't distinguished in consciousness. I don't have a place in a little file cabinet in my mind that says, this is where I put my hopes and dreams, and this is where I put absolutely the things that happen to me. And as people know, and who know me, when I'm talking about stories, I occasionally embellish them to make them a little more interesting. And although I may know at first that I'm embellishing them, I need other people who know me to remind me of times when I've gone too far with the fish story, because you gradually lose it. So Freud saw that and said there's no criterion. And finally, and again, most telling and showing that he's a doctor of experience, he said such memories never emerge in delirious patients. And we do know that delirious patients often do relive their past experience. And he said it didn't occur. Now, when you say, will it ever occur? Well, I suppose it might, but these are for very good reasons. Now, another reason for holding the thing I do, I want to come back to the abduction phenomena, the alien abduction phenomena, because I think it's telling to develop a background idea. I'll read it to you. This is a quote from John Mack from the Harvard Medical School. Everybody's heard of John Mack now. He's the person who believes in the abductions. And he says, again, it's a question of clinical judgment. No one would deny that. When memories come back like that, and by that he said, when memories come back with feeling and emotion, I never have any question that these people are describing something that has authentically happened to them. Okay? The emotions are such, and by the way, that happens in these other things. People have so much feeling about it that it's hard not to believe them. And that's what he's saying now about something we all agree is absurd, the alien abduction. The patients say, gosh, with all this feeling. But then John opens the door when he says, no one has been able to come up with a counter-formulation that explains what's going on. When you do that, whoa, no one, okay? I think it's interesting because not only I and you and other people might be able to give a counter-formulation. This man did, Carl Jaspers. In fact, when people think they've discovered something new, it is always the experience of neuroscientists, psychologists, and psychiatrists that it's just an evidence that you haven't read the German literature, because it's there. And it's here in Carl Jaspers' General Psychopathology, and he's quoting some worthy Germans from about 1912, okay? And by the way, when we're told that it's not in DSM-4, so therefore it can't exist, well, it's certainly in the General Psychopathology. Page 76, if any of you want to look it up. Carl Jaspers, quoting from the German literature, has had a number of cases in which he said the patients know for certain that what comes back to their mind is something they have forgotten. That's the first thing. They say, you know, it happened to me, but I forgot it. Now I've got it back. Secondly, they feel that they were in some abnormal state of consciousness, half asleep, faint, a little baby, not really with it, and the like. And finally, they feel that they must have been the passive tools of someone or something and could not do anything about it. They're carried off into spacecraft, or they're tied down, and things of that sort. Now, this is this is the observations that have been made again and again in relationship to our conditions, and they have the standing of a tradition that goes back close to 100 years. Now, what do I think the energy of all these things depends on? Again, I think that there is something here as well, and I want to go over this quickly, but because on this, it's only a matter of judgment, and I don't have data, really, that says that this is correct. But one of the reasons that is going, that produces the energy behind these false, the commitment to these false memories, is the natural concern for children. I mean, we are concerned that children are not abused, that they are protected, that their innocence is sustained. All of us feel that way. That's why we claim again and again that there's nothing that we're saying that should be protective of anybody abusing children. We hate that in this room just like everybody else hates it. But this concern, if tied to the public credulity towards experts who propose that this must be happening, leads to this division in our world and field and gives some energy to the belief. The third reason, I believe, is that there's a great suspicion of the mediating institutions in our society. It's been going on for maybe 25 or 30 years. It may have been generated in part by Watergate, but Watergate might have been a symptom of that as well. But for about 25 or 30 years, we've been extremely suspicious of the very institutions that previously we had thought had protected us from mistreatment and protected us from while we were developing and gave us a sense and rootedness in our world. That is, institutions like the family, the churches, the schools. They're all under assault now and have been for 25 or 30 years. At least they're on the defensive, and certainly the family is, as a source where we had previously thought of it as a place where good emerged. Now it's thought of as a paternalistic place. And then I leave here as a final point for you, comes out of these ideas. Where in the name of heaven do these awful ideas of sexual life come from that emerge in the course of therapy? They are the vilest kinds of ideas. They are anti-erotic in many cases. Where do they come from? Well, I don't know. Some people would say, well, that's all buried in there anyway. But I do believe that the last 35 years has seen the emergence of an industry of pornography in our country. And I believe the imaginative world of our people has been polluted by pornography. I finally had to come around to agree with that. And by the way, now again, it's not that I'm not saying this just out of the sort of sense of this experience. There's a historical background to that. And which, if any of you read the wonderful book by Simon Schama entitled Citizens, the description of the emergence of the French Revolution, you probably all know that a big influx of pornography occurred in pre-revolutionary France and was related in particular to the royal family. And you probably also know that Marie Antoinette was accused at her tribunal of having sexually abused her small son. And she turned to the audience and said, would any mother believe that I could have done such a thing? And for a moment, the women, even the knitting women, rose to applaud her and said, so this idea of the pollution of the imaginary world, It has some historical background to it. Well, in fact, I think that this situation that we've become involved in is a belief system that tends to take from a lot of things to produce a dynamic that is a juggernaut in our world. That is, the distrust of the family and the idea that paternal dominance is happening can lead to the idea of sexual abuse, particularly if sexual abuse is enriched by pornographic thoughts on somebody's part. That sexual abuse is presumed to provoke silence in the victim. By the way, we have no evidence for that. In our experience with pedophiles, when they are accused by their family of it, and their family very often does speak about it, they admit it. Presumptions about secrecy and silence doesn't seem to work out in the experience of the confirmed pedophiles that we have. Then silence can beget forgetting, particularly if an issue of repression, particularly repression thought about not in the way we were talking about yesterday in the question and answer, but thought about as something that could completely silence fact. And this, I put this out as a paranoid belief system because I want you to see that we're involved in a repetition of other experiences that have happened in societies where a set of ideas, sometimes out of a culture, sometimes out of media, sometimes about presumptions, has led to the persecution of marginalized people. Black people lynched in the South because of some presumptions about what their thoughts were without looking for evidence. Jews in Europe presuming their role in the society. Homosexuals. We have been taken up in this situation and repeated for ourselves and suddenly find ourselves involved in and victims of a social movement that has had victims before, and they have victims now. What kind of victims? Well, the victims are many. I just want to just show you one. What are the outcomes, you see? What are the outcomes of my group of families? Well, just let me read you this letter written by a daughter to her mother. The mother wanting to try to put things together while the father was accused. And can you imagine receiving this letter? And by the way, can you imagine how a therapist who could have generated this letter should feel? You cannot ignore your relationship to your children and expect the privilege of being a grandparent. You have to be a parent first. Your blatant inability to give to me, to respond to me, to choose me in all of this has finally become too much for me to ignore. Your choices, your actions over these past 2.5 years have led me to decide that you can no longer see my children or grandchildren. It is not that I have stopped wishing, but rather that I have to stop sacrificing myself for you. I cannot imagine what satisfaction you find when you reflect on how you have lashed out, never actually reaching out these past years. I cannot imagine what peace you have when you reflect on your ability to be a mother, having given up your daughters. You have said that you are caught in the middle and you don't know who to believe, but your actions speak louder than words. Your allegiance to him is clear. Perhaps you don't care about what kind of mother you are. Now I submit to you, any doctors, any therapists who have generated this kind of hatred between a daughter and her mother should think very carefully about their responsibility. This is the kind of lynching we are involved in trying to stop witch trials and the like, and this is the kind of burning or lynching that can occur. Now, these are to the spouses of the accused. The spouses are being hurt in the process. Now, all of this, by the way, was speak to you about the issue of standing before I talk to you about the do's and don'ts and how to practice here. You have to have standing if you want to tell people what to do, after all, and I hope you will agree that this review of a personal experience, of the standards of practice, of the issues and the logics of the situation gives some standing to the following prescriptions. I think in dealing with a memory that has occurred in relationship to either a person who comes to you or has something emerge, that you should have 4 do's and 4 don'ts in relationship to that memory. The first do is to observe the genesis of that memory. By the way, these are very standard things for psychiatry. We're not talking about things that are unique or special. We do this all the time. You should observe the genesis. If the genesis of this idea came under hypnosis or the like, in that kind of situation, and it was never accompanied with any suspicion or thoughts of it before, you should be suspicious of it. If, on the other hand, it was a memory that the patient had, a thing that, an event that had perhaps been not in constant thought, but had been there for a while and knew that it happened, that would be different. By the way, I once had a patient presented to me by one of my residents who said that he was going to show me a sexually abused person, and I said to the person, "Gee, I'm very sorry, will you tell me about it?" And she said to me, "Oh, I can't tell you, you got to ask my sister. She's the only one who knows what happened. I don't have any memory of it." And she told me about it after she went into therapy. And I spoke to the resident and said, "Gee, you know, that's not the way to make a judgment." Well, not all of my residents agree with me. That's part of life. You should consider its content. If the content is that I remember a memory when I was 10 months, that's different from saying I remember a memory, I have a perfect memory of something that happened to me in my teenage years and or in my 8, 9 year old. That's different. You should seek its confirmation. You should be in touch with members of the family, several members of the family, particularly members who are not in psychotherapy, so that you can find out what was the nature of that family life and see what other kinds of confirmations you can find. You should attend to the accompanying syndromes, because certain of these syndromes can produce delusional beliefs, and certainly any of them might be the source of the problem that needs treatment, and you shouldn't neglect that treatment to see if it would disappear. Yesterday we talked, for example, about the use of medications amongst people who are suffering from obsessive-compulsive disorder. There are 4 don'ts, and they're very obvious don'ts. Don't propose devices to patients. Don't say to patients, have you heard about repression? I mean, we had a conversation yesterday amongst professionals about the issue of repression, which is an interesting one. We're not even clear ourselves exactly what we encompass in it, but plenty of therapists talk to their patients about repression as a dynamic process. You shouldn't do that. We don't ordinarily. We use it to explain what we know to ourselves, but not to them. You certainly shouldn't talk to people about alter personalities, and try to persuade them. How many do you have in there? You shouldn't be proposing devices. You shouldn't provide suggestive workbooks like The Courage to Heal. You shouldn't prescribe group attendance, and you shouldn't encourage a memory with hypnosis. I think those are all fairly standard things. What should you do in treatment? How should you, supposing you've decided that this is an artifact that has been produced, what should you do? Well, the important first thing to do is to decide and to make your mind up by looking carefully at all the evidence you can find. People who have been abused and whose families are members of abuses should be treated for that. You should get on with treating that. But if you decide that this is an artifact, you should also decide that. If you do, then you should isolate that patient from other sources of contamination. You should get them out of dissociative units. George Ganaway may be an exception, but most dissociative units keep people enthralled to this idea of multiple personalities and hidden sex abuse. And you should begin some form of counter-suggestion. Now, what do I mean by that? The counter-suggestion is really very easy. You turn your eyes away from being interested in multiple personalities. You don't go for the 69th or 70th personality. You stop keeping records of personalities. and you start talking to the people about what's happened to them here and now. You say, that other stuff will take care. By the way, I don't grab people by the lapels who claim they have multiple personality disorder and try to shake it out of them. I say, well, that's interesting, very good, but it'll get better. Now tell me what's happening to you right now. How are you doing? What's happening at work? What's happening with your family? What's happening with your husband, your children? We get on talking about that, and gradually the attention turned to this other thing is the ultimate counter-suggestion that the important thing that is happening right now is in the here and now with you, and that eventually we might find and understand why you had those ideas when we understand that. Comorbid treatment means just what it says. If you discover that the person has a major depression or obsessive compulsive disorder, you should get on with specific treatments for that. And then finally, you should start working on the treatment of the demoralized state, and particularly some rehabilitative psychotherapy for the individual and the family. And this is the very tough part. Fortunately, we have today coming to talk with us and demonstrate with us with a family, the two Drs. Schaff from Washington, D.C., who have worked with families on this matter and show us matters of rehabilitation. I'm running out of time. I want to remind you that there should be some, if there is standing, there should be some outcome measure. Well, my outcome measure with this treatment procedure is that I've got 40% of my patients to at least retract and get back on the track. I mean, that does it. Finally, what do I really think is happening? I think that we are in the midst of a craze, and crazes have been described before. Lionel Penrose described crazes. By the way, crazes are of all kinds. Some of them are very innocent crazes. The hula hoop was a craze, okay? It had its life. You remember the hula hoop. And it was great. But they go through 5 phases. There's a latent phase for a craze in which a particular idea is in a few minds but not spreading. And that, for example, was the state of our business, I think, before the writing of Sybil. Then you enter an explosive phase where the idea spreads exponentially within a community of interested people. And that's what happened here. By the way, all kinds of paranoid ideas spread in exactly the same way. The explosion, the idea of anti-Semitism in Europe in a few minds, but then spreading exponentially in the German community. A saturation phase for a craze, the market of susceptible minds in the community becomes saturated, and the number of new converts slackens. I think that's where we are with our craze now. We, I think, are contributing to the beginning of the immunity phase, where resistance to the idea develops within the community. People now are hearing, I mean, judges and jurors and other people are hearing about the false memory syndrome, and that's immunizing people against it, and enthusiasm weakens for it, even amongst the initially involved. And when I hear and read about how the initially involved begin saying, "No, you got to be careful now about this," I know that we're coming into the immunity phase because, let me tell you, just 5 years ago, the idea that there was anybody with a false memory syndrome, and you mention that, you're likely to get hit. And eventually it gets into the stagnant phase where the idea fades away, except perhaps in the minds of a few enthusiasts who are always left, and remain the few minds that can start it up again at another time. But we're not there yet. That's where we're going, and it's coming along. I don't think I need to go over that again, but I always like to end up with this quote from Oliver Wendell Holmes, the doctor, not the jurist, that the truth is that medicine, professedly founded on observation, is as sensitive to outside influences, political, religious, philosophical, and imaginative, as is the barometer to the changes of atmospheric density. That's true, and that's the reason why medicine can sometimes be the source of great paranoid beliefs and great injuries to the public. Thank you very much.